And a warm welcome to today's edition of Patcast. Today is October 17, 2023, and it's a Tuesday. I'm Rifat Manan in California, and I am remotely joined by my good friend Emilio Madrigal in Boston. Today, we are very delighted to welcome back Dr. Lester Thompson, who needs no introduction to the pathology community. He is a very renowned head and neck pathologist, and he now heads the head and neck pathology consultations. And today he is going to give a talk on WHO update on head and neck tumors, and it would be a multi-part talk. So this is part one, and he has titled it as Towards Extinction of Not Otherwise Specified WHO Head and Neck Tumors Classification, 5th edition. And as always, please feel free to post your questions and comments on Facebook and YouTube chat windows, and we will pass them on to Dr. Thompson towards the end of the session. And thanks for joining us today, Dr. Thompson. Over to you now.
Thanks. It's my pleasure to be able to join the session. And it's always fun to talk about something where you feel that you have had the opportunity to sort of change what is going to happen in another edition. And so with that, I'm actually going to turn off my video just so the whole screen is shared with you guys. And it is a interesting thing that there are enough changes that in fact we're going to do a part one and a part two. And so with that in mind, let's start off. Of course, I do have the disclosure that I was part of the standing editorial board for the entire 5th series, and then also serving as an expert member for the 5th edition of the head and neck tumor book. And of course, you know, you have some books that pay you 2 cents, but you still have to talk about the book royalties. So, you know, if you don't know the names of things, the knowledge of them is lost as well. And this is a quote from Carl Linnaeus, one of the first individuals to come up with a taxonomy, and it was used in the biologic community at that particular time. And even though that taxonomy is still used today, of course, it's gone through multiple iterations. And so that's exactly the same thing as what we're trying to do within the World Health Organization classification, because truly, if you give the correct name to a cancer, then you really are on a mission to be able to defeat the tumors correctly. So just from a kind of historical standpoint, as you know, 1956 was when the WHO became responsible for the classification of this all organ tumors throughout the body. And it's an evidence-based classification of cancers to be able to enable both diagnosis and research worldwide. And because it underpins everything that goes on in the treatment, it really is a book that is not just for pathologists, even though many times we look at it and say, you know, most of it is written from the perspective of a pathologist. I think with this edition, you will notice that it is a much broader approach to disease in general. So let me just highlight from a very high standpoint some of the major changes within the 5th edition. And that is, you know, first of all, better governance. The idea that this is a editorial board that was started in 2017 with standing members. Those particular standing members were involved in then selecting some of the expert members to lead the various classification groups and using an informed bibliometric to come up with the various authors that were involved. And you can see in the entire 5th edition, more than 2,500 authors from around the world are involved. So it really is a huge number of people to be able to manage and get all of them to write their particular sections for each of the various books and chapters. Another one of the things that is great is that the World Health Organization has really integrated their approach with the coding, the ICD-11, the various staging systems from UICC, AJCC, as well as the ICCR, getting a number of other organizations to feed data and information into the WHO, but also allowing the WHO classification to feed back out into those systems as well, to allow for a standardized approach globally to what it is that we do with pathology and the tumor classification. Of course, it is also an idea that it is a single hierarchical classification. So, you know, I mean, if you went to the old WHO books, you may have seen that, let's just use squamous cell carcinoma as an example, it would have been presented 7 or 8 times based on each of the different anatomic sites within just the head and neck, let alone squamous cell carcinoma being presented, you know, another 70 or 80 times throughout the rest of the volumes. And so we decided with this 5th edition to try and really harmonize and improve the classification where you're not going to have multiple definitions of things. So if a squamous cell carcinoma is defined one way for one anatomic site, it really should have that same principle apply no matter where it is in the rest of the body as well. And so this particular standardization, I think, really is harmonized specifically around the neuroendocrine tumors, the hematolymphoid soft tissue, and of course, the melanocytic tumors, as well as getting a standardized approach to familial syndromes. And in fact, this is the first time in any of the editions that there has been the entire book just devoted to familial syndromes, and that was the last one that has come out in beta version on the website presently. There was also a major emphasis on trying to get image improvement, linking all of the references so that PubMed is kind of the primary source for all of them, and then standardizing global epidemiology and standard units. So mitosis per 2 square millimeters is now the standard across the board, rather than having, you know, per 10 high power fields and what's your high power field and what's mine. So that's a major difference in how we approach this book as well. And then the website is, I think, one of the most significant enterprises, and I'll talk about that here in a few moments. So here is just an example. This happens to be the staging form from the ICCR for major salivary glands. It doesn't matter which one, they have them for all of the anatomic sites of the body, but this is a way in which globally everyone can use the same standard way of reporting things. And so you have a reciprocity between nations. So what you're calling something in Sri Lanka or in South America or in North America, you're all going to be doing the same thing and having the same information captured. So I always think it's fun to kind of put things a little bit in perspective. You know, we do change over time, but I did think it was kind of funny that this was the World Health Organization classification from the 3rd series, and you can see that this is July of 2003. Yes, I was standing there. But then, you know, a few years later, you'll notice that I didn't really change positions. We just went inside, and here we are now in January of 2016 for the 4th edition with several of the same faces appearing, although some new faces were added. And then lo and behold, with the pandemic, of course, that changed and there was no longer any pictures. And now we were all just little Zoom icons as we did our meetings online for this particular edition. So it was not a pleasant way in which to do so, but I will say trying to get literally every one of the 24 time zones coordinated into these meetings meant that several of us here on the West Coast and those in Japan were always at some weird hour of the day trying to actually get the work done in a meaningful fashion. So, you know, if you looked at the 4th edition of the WHO, there were 4 editors involved in that particular book, and yet in this one, there are 19. So a very dramatic shift in trying to share the load amongst individuals, but also to try and get as many major leaders in the field to be able to participate in their areas of expertise. So you will notice that the 19 individuals who handled the various topics are listed here, and there are 4 of us who were on the standing editorial board. So in other words, I'll just choose myself because it's easy to do that. But, you know, for me, it meant that whenever head and neck related tumors were covered, let's say secretory carcinoma being presented in the breast, I was able to give some of the findings from ours in order to coordinate the cataloging it in the breast book. Or if there was the pediatric book, I would be the one to be able to harmonize the terminology for all of the head and neck organs for that particular book. So I think that Tony Gill and Joe Curry and Alex Lazar did all the soft tissue things, with each of us having a particular role for the entire series, meant that we were always involved in every one of the books, so that if you look at a pediatric book and it's talking about pleomorphic adenoma, it's going to have exactly the same criteria as what you see in the final edition of the head and neck book. So we covered 253 unique entities in this book. Subtypes is now the term that is used rather than calling it variants. Variant is only used in molecular classifications. So if you have pathogenic variants in that particular group, then you can call them a variant, but otherwise subtype is the new name for any diagnostic category under an overarching group. 288 authors were involved from 35 different countries with a hierarchical classification. So, you know, I never understood why in the old WHO books, we would start off with the malignancies and then kind of end up with, you know, what are these things? Are they reactive? Are they not? Are they the, you know, newly upcoming entities or whatever. So in this particular edition, we chose to incorporate several of the hamartomas or reactive tumor-like lesions only because they either clinically or histologically are a mimic for a neoplasia, and therefore you want to make sure that in those particular settings you're not going to have a misdiagnosis, but because we've presented the information, you're able to put it in the context of the rest of the lesions. And then, of course, going to benign tumors, finally going into the uncertain or borderline lesions. And then with the malignant tumors, trying to establish an order from low to high grade. So in other words, the tumors that are at the very end are often those that are the most biologically aggressive. Now, I will say that sometimes if they are exceptionally rare as a lesion, they may actually be at the end of the book too, just so you've presented the major classifications of some of these lesions, especially when you talk about salivary gland tumors and things like that, where you have, 30 and 40 different entities. You don't want to have something that is incredibly rare as the number one entity, because then people are going to be like, wait, I thought adenoid cystic or cynic cell carcinoma should be there. But for the overarching role, we did try to go from low to high grade. Now, I think the most major change that all of you will see in this book, and I think it's a very, very significant one because I don't want people to be misled or misinterpret the findings, but there was a attempt to try and reduce redundancy or repetition so that there is no duplication between books. So pleomorphic adenoma is only presented once. It's presented once in the salivary gland chapter. However, pleomorphic adenoma can certainly occur within the larynx. It can occur in the nasopharynx. It can certainly occur in minor salivary gland locations in the oral cavity. We see them in the external auditory canal. So there are clearly places where tumors are going to be identified that if you were just to go to, let's say, the ear and temporal bone chapter, you are not necessarily going to find any salivary gland listings in that location, because instead they're all aggregated. So that's the case for all of the salivary gland tumors, which is the most unique and specific to the head and neck. But very similar to the rest of the anatomic sites, the same thing was done for soft tissue lesions, for hematolymphoid proliferations and neoplasms, for the melanocytic lesions, for metastases, for germ cell tumors, and then, of course, for bone tumors unique to the head and neck. They were actually classified within the odontogenic or maxillofacial bones, since that's the anatomic site that is unique to this area. Neuroendocrine tumors, as I already suggested, had a major overhaul where all of them have been pulled out. So if you look in the sinonasal chapter, you are not going to see neuroendocrine carcinoma in that location, even though clearly it is involved. Same thing with larynx. You're not going to find the neuroendocrine tumors there. It is not that they don't develop in those locations. It's just that we have tried to aggregate them so the information is not repeated again and again in multiple different sites within the book. And then the final thing that was unique is for those genetic tumor syndromes that have a major manifestation specifically within the head and neck as one of the primary lesions that we see, those particular entities were included in this book. Now, we do recognize that the genetic tumor syndromes often can have a wide diversity and range of different tumor types, and sometimes head and neck related lesions would be seen, but not the major manifestation. And so in that case, they would not have been incorporated here, but instead just in the genetics tumor syndrome book. So if there is anything that you learn from this going to tumor classification, and please note tumor is T-O-U-R, T-U-M-O-U-R, so the U is included because it's the British English version of it, and tumorclassification.iarc.hu.int. This is the place in which you can go to see all of these books online. It is a modest fee of, I believe it's still €100 in order to have a 1-year subscription to it. And after I talk about it a little bit more, hopefully you will recognize that that is quite good. There are discounts given for those in developing nations as well. And so I think it's a fantastic way to have literally the 15 or 16 books that we have in the series all at your fingertips, immediately accessible no matter where it is that you are. And so I really think that as we go through this particular classification, and you can see all the books with the addition of the head and neck book, and this is not the official cover. This is one I have mocked up because I don't know what it is yet because the book is not published, but hopefully you'll be able to enjoy that book. So if you think about the website, with the interactivity and the online book, it's really optimized for both desktop and mobile application. The online version clearly can have many more images than what you see in the printed book, because many times you're limited by the number of pages, and so you may only have 1 or 2 selected images in the printed version, and yet you may have 10 or 12 in the online version. So it's a really remarkable benefit to you. And then I think the most significant thing, we were not successful in 100% of the 5th edition. I mean, there are just some things that didn't happen as they should have. But for the head and neck book, I think I can assure you that with some very rare exceptions, there is a virtual whole slide hosted for every single major diagnosis in the head and neck. So this means that you as a user can go onto the site and drive a case that has been vetted by one of the expert authors and or members of the editorial board to be able to see what a case looks like in real life. Now, we've tried to optimize them in the sense that there are no chatter areas, there's no folding, it's good histology. But, on some of them, that's just not the case. And when you look at it and you're like, oh, this is a terrible slide. And you're like, yes, actually, this is what you're looking at under your microscope right now. And it is a closer match to reality as we could get. So I do think that that particular idea of being able to look at it, you can actually do screenshot capturing from the site as well, so that if you needed it for a presentation or something, you would be able to use it. And those particular virtual slides are going to be made available for AI applications as well, such that people will be able to have some standard that they can look at for these. Again, one of the other things that's fantastic is with the virtual book, you can just click on the PubMed identification number and it automatically opens in a new window directly through to PubMed, and you're able to look at the source information upon which the data you have just read was based. And that, I think, is a very powerful tool, especially when you're dealing with clinicians that would like to know more specifics about the diagnosis that you're actually giving. So with that in mind, let's actually now start with some of the classification items. And of course, the first chapter happens to be the nasal cavity and paranasal sinuses skull base. We did try to do it going from top down. So the skull base, of course, is the highest area that we could do. And so that's the reason for being the first chapter in this particular instance. Oh, 1 second. You will notice with every successive edition, there are fewer diagnoses. So you may say, how is that possible? But it is because, if you take out all of the soft tissue lesions and the salivary gland things and the duplication with hematolymphoid, you suddenly are left with not such a huge number of new entities or things that you need to come up with as diagnostic entities. So the new lesions for this particular book actually were incorporated as emerging lesions in the 4th edition, and that is the Sweetness complex deficient sinonasal carcinoma and the HPV-related multiphenotypic sinonasal carcinoma. Those are the 2 new validated and verified entities that are included. Because of the way in which we incorporate new entities, the IDH2 hotspot mutation category as well as the DECAF2 category, both don't really have a sufficient number of cases reported from various groups in order to give a legitimate name to them, how they're going to be developed, where are they going to fit in. And so you'll notice these are provisionally included under their own specific categories as entities that probably by the time we put out another edition for the 6th version, hopefully would be the case. And similarly, several things were, updated as you would expect. So I'm going to highlight just a few of these changes, specifically with the sinonasal tract. I'm actually going to present some of the data around the entities from which they have been drawn out, just so you'll understand it a little bit better. So if you think about the Sweetness complex group, this is a deficient carcinoma. So in other words, there's loss of that particular analyte, whether it's SMARCB1 or SMARCA4 is the 2 most frequent Sweetness variants that are identified. And there certainly are others in this particular family, but these are the most common, with the SMARCB1 probably the most common entity within this group. Now you may say, well, what does SMARCB1 stand for? Well, it stands for Sweetness-related matrix-associated actin-dependent regulator of chromatin subfamily 1 member, subfamily B member 1. Okay, so you clearly are not going to want to say that particular name every time. So hence SMARCB1 and SMARCA4 are what we usually abbreviate them to. Within the head and neck, these are generally considered to be the sole genetic driver of the disorders, and it's a biallelic inactivation. Interestingly, especially for SMARCB1, it is quite close to the Ewing sarcoma or EWSR1 gene, and therefore sometimes a FISH evaluation may give you a false positive. And so this is actually an instance where doing the immunohistochemistry is actually more meaningful because you're able to get, loss of those particular genes much more readily identified. So slight male predominance, paranasal sinuses, and they usually present with a very high stage. Overall outcome is still not very good for this particular group. So they have been divided out into three major groups: the SMARCB1 deficient carcinoma, then the SMARCB1 deficient adenocarcinoma, and then finally SMARCA4 deficient carcinoma. So each of these entities has a very specific morphologic appearance to it. Probably that basaloid or plasmacytoid rhabdoid appearance is seen, although with the SMARCB1 deficient adenocarcinoma, sometimes you may even have some yolk sac-like features, and it tends to be a much higher grade overall tumor. Now, sometimes we try to classify these a little bit further in saying that there isn't really any good squamous differentiation, but I will say sometimes they will have P63 or P40 and sometimes even CK56 present within them, especially within the SMARCB1 category. So you, by definition, need to have loss of one of the entities, either INI1 or BRG1, both reflecting SMARCB1 or SMARCA4 respectively. And so this is kind of the classic morphology. It has a very plasmacytoid to rhabdoid appearance with the eosinophilic cytoplasm pulled off to one side. As you will notice in these cells especially, they just give you a very nice appearance with the nucleus set off to one edge. And in this case, you can see from an immunophenotypic expression, you may have some CK56 or P63 expressed, even P40 sometimes, but it is going to be positive for the pancytokeratins showing loss, in this case of either INI1 or BRG1. So this is an example of INI1. Because it is constitutively expressed, you will notice that all of the rest of the nuclei in the adjacent fibroblasts and endothelial cells are going to be positive. So it is really nice when you're dealing with a loss of a marker to be able to have a strong internal control to make sure that it has worked, because it's always a bit awkward when you're saying that it is a loss of a marker or deficiency of a marker that puts you into a particular neoplastic category. And so that is just an example of loss of INI1 in these tumors, allowing you to place it into the SWE/SNF category. I will say when I work up these particular cases, they often are somewhat difficult to get your head around, because they do seem like they should be, a carcinoma, and yet nothing seems to be working. So if I go back just a slide, you will notice that in a panel approach that I do for the immunohistochemistry evaluation of sinonasal tract tumors, you will see that INI1 and or BRG1 is included. And the reason for that is if you have loss of it, it doesn't really matter what all of the other things are, with kind of the exception of pterygocarcinosarcoma, but it allows you to actually put it into a defined category immediately. So then it is actually quite rewarding to know that you, can put it into a defined category without sort of waffling about what the diagnosis may represent. Now, let me just say, I said the exception was pterygocarcinosarcoma. So as you know, this is a lesion that has a very complex neoplastic appearance, because it's both immature as well as malignant, both endodermal, mesodermal, and neuroepithelial elements. So you have carcinoma, you have sarcoma, and then you have these immature neuroepithelial elements. So depending on which area is sampled, especially if it's core needle biopsies or limited biopsies, you really can be misled in the interpretation. But because it is a very specific and unique entity within the head and neck area, we have kept it as a defined entity, even though you will notice that it does show loss of SMARCA4. So this is a tumor that isn't put in with the rest of the SMARC or SWE/SNF complex deficient group, because we feel that it is still a unique entity that can be recognized based on its histologic parameters alone. So just an example, you can see a very complex pattern, the neuroepithelial type appearance or very primitive appearance throughout the center of this particular area. And then, of course, you have areas in this space where you have evidence of squamous differentiation as well. Abrupt keratinization can be seen with this very primitive appearance and then mesenchymal component in the background as well. And then, as I said, the loss of BRG1 or SMARCA4 helps to confirm the diagnosis. As you would expect, the immunohistochemistry is quite complex because each of the various elements has its own unique immunoreactivity pattern. Then let's go into sinonasal undifferentiated carcinoma. The only reason I'm including this because it really is now a diagnosis of exclusion, as you would expect. And many of the lesions that I'm talking about already, the SWE/SNF complex deficient carcinoma group, most of them came out of this sinonasal undifferentiated category. And so again, you need to have excluded some of these other entities. It is a very destructive tumor, lots of necrosis, lots of bone involvement, usually having some sort of lymphovascular or perineural invasion. And by definition, it really cannot have any either squamous or glandular differentiation. So looking at the surface will give you some clue to that, although I will say that depending on the biopsies, many times the surface epithelium is denuded, and therefore you're not able to actually see them. One of the diagnostic category features, for me at least, is this very large round nucleus with a vesicular to open chromatin and a prominent nucleolus. And that, I think you will notice, as I just showed with the SWE/SNF complex deficient group, had that same large nucleus because many of the cases were pulled from this particular category. So you'll see a large destructive neoplastic process here, lots of vascular invasion with tumor emboli filling into vascular spaces. Bone destruction can easily be identified, and I think even on this power you can see that it's a very open nuclear chromatin, very prominent nucleoli present within the neoplastic group. And of course, again, there should be no evidence of squamous differentiation or glandular differentiation, but still as a carcinoma showing strong keratin, whether it's pancytokeratin, AE1, AE3, or perhaps Oscar, whichever one you use in that particular entity. So here's just an example, CK7 giving you a very nice strong reaction. And in contrast to that, you will notice here are some of the squamous markers with either P40 or CK56, not really giving you a reaction in the neoplastic cells at all. Sometimes it will highlight some of the cells at the periphery of the islands, but definitely the major tumor is not reactive. Now, one of the unique findings for the sinonasal undifferentiated carcinoma is IDH1 or 2. And in this particular entity, as I've already suggested, because there is a mutation identified specifically, and there are some monoclonal antibodies that can be used to detect the mutant IDH1 or 2, is the idea, is this actually a unique entity? In other words, is the IDH1 or 2 mutation actually defining the tumor or not? Because there's several different tumors that have this particular finding that are being classified differently at this particular point. And so even some of the neuroendocrine carcinoma groups can have IDH1 or 2 mutations. So therefore, at this particular juncture, sinonasal undifferentiated carcinoma with the IDH1 or 2 mutations is quite helpful in confirming it, but just recognize that there is much more work to be done in this particular tumor that otherwise has a really, really poor overall outcome. Now, I just want to mention nut carcinoma. It was included in the previous edition, but of course, it's kind of the same idea where it's being defined by its molecular abnormality. And so you get these sheets of neoplastic cells. They are often very, very monotonous. So whenever I see a tumor in the sinonasal tract that is a very monotonous tumor, the cells are atypical, but they're all monotonously similarly atypical, then I worry about the idea of having some sort of either point mutation or fusion as the major driver for that particular tumor. Now, it's nice if you have these areas of abrupt squamous differentiation. I do like to see them deep in the tumor rather than near the surface, because sometimes is it actually surface epithelium that's showing dysplasia, and then this is the tumor, and therefore could it be just a squamous cell carcinoma that's poorly differentiated or non-keratinizing, or is it actually a nut carcinoma? One of the other things that's unique with nut carcinoma is it tends to have a very prominent inflammatory infiltrate. Here you can see with acute inflammatory cells present throughout, sometimes in such an overwhelming amount that it's hard to see the neoplastic cells, and looks a bit like nasopharyngeal lymphoepithelial carcinoma category, where sometimes the number of neoplastic cells is obscured by the inflammatory infiltrate. Well, the easiest way now to confirm nut carcinoma is, of course, doing a nut IHC. As you know, it's this very fine speckled appearance in the nucleus only, and I do stress it needs to be nuclear only. I have actually seen several cases where it's been called nut carcinoma and sent in for a second opinion, and it's cytoplasmic only, and therefore it is not a legitimate finding. As you know, nut carcinoma has an absolutely dismal prognosis. Primarily because of its anatomic site. In other words, it involves the skull base very frequently, and many of the chemotherapy agents do not cross the blood-brain barrier, and therefore the patients do not have a good outcome, even though they may be on clinical trials because of that particular finding. So if you're going to give nut carcinoma as a diagnosis, you need to be really sure. Many times one can actually do further evaluation. Certainly FISH can be used, or RT-PCR, in order to be able to document the exact fusion partners, in order to be able to have the correct therapy offered to the patient. I do think one of the unique things about the fish, though, and I'm going to put it in here, is this is a jellyfish I was able to photograph in the Monterey Bay Aquarium. And the reason this is interesting is the actual fluorochrome that provides the fluorescence for this jellyfish underwater. The red is what is used now in fluorescence in situ hybridization. So I thought that it was fascinating that we have this particular gene from a jellyfish being used in our fish evaluations clinically. So carcinoma X sinonasal papilloma is not really a new entity in the book. It's definitely something where we talk about transformation or malignant transformation based on the various types of sinonasal papillomas, whether it's inverted or oncocytic or exophytic. But I am including it primarily because in this particular case, you have this dominant mass, you have the areas of carcinomatous transformation of volume of disease. There is often a very abrupt transition from areas of the benign to the malignant. And then here you can see the surface epithelium is completely dysplastic, in fact, even having small single cells isolated in the stroma as it invades into the adjacent tissue, sometimes even having paradoxical maturation right before it invades into the underlying stroma. Of course, atypical mitotic figures are usually very easily identified. And one of the unique findings is the loss of transepithelial elimination of the acute inflammatory cells. So the benign side, you will notice that they are these little abscess-like areas, or microcysts as we call them, filled with necrotic and degenerating acute inflammatory cells that you can see migrating through. Whereas in the malignant area, it's completely lost. And the reason I'm highlighting that is I'm going to talk about DACAF2 carcinoma here in a moment as the corollary for this particular lesion, or the thing to think about when you're talking about carcinoma X sinonasal papilloma. Many times, the sinonasal papilloma that undergoes malignant transformation will have a very strong and diffuse p53 based on an underlying mutation in that gene, or the TP53 gene. Now, the reason I included that is primarily because of DACAF2 carcinoma. So this is an emerging category. It's often an incredibly complex, both endophytic and exophytic papillary pattern, growth patterns to it, large anastomosing lobules, and just a sheer volume of tumor is just so overwhelming that you just are like, wow, this has got to be some sort of malignancy. Now, what is interesting here is there is just an amazing number of tumor infiltrating both lymphocytes and neutrophils. And so it's actually the opposite of what you see when carcinoma develops within the sinonasal papilloma group, where they're lost. In this particular category, they are actually very, very prominent. And of course, at this particular point, it is a molecularly defined tumor, and therefore you do require having DACAF2 fusion either through a RNA sequencing or FISH break-apart probe. There are also fusion probes, and recently the identification by immunohistochemistry raised to the AF2C terminus. It's not quite commercially available everywhere, and so it's a nice thing to do. There have been a few papers on it, but I still think that at this particular point, either the fusion or break-apart is probably the best way to confirm the diagnosis. So here you will notice, sheets and sheets of tumor, right? I mean, mean, it's a very large volume of tumor in this particular case. You will notice that there are often these histiocytes that collect, and they're foamy histiocytes. So in the sinonasal tract, whenever I see foamy histiocytes all over, my index of suspicion for some sort of malignancy going on in the background is raised. And then here you can see a sheet-like distribution of these neoplastic cells with a myriad of acute inflammatory cells, often throughout the entire epithelium, as well as in the underlying stroma. And then if you do the DECAF2 fish, you will notice this happens to be an example of the fusion fish, giving you a strong positive result. So one of the new other entities that were included in the book is the HPV-related multiphenotypic sinonasal carcinoma. This particular entity has surface epithelial malignancy, as well as what looks like minor salivary gland malignancy elements, with a strong association with transcriptionally active HPV. And in fact, that's part of the definition of the lesion, usually with HPV serotype 33. So in this instance, they actually have an excellent overall long-term prognosis. And so this is the reason for separating them from adenoid cystic carcinoma, because adenoid cystic carcinoma, as you know, has a very indolent but still progressive recurrence rate and metastasis to ultimately result in the patient's death. So these tumors are still remarkably destructive and remarkably malignant in their appearance, and yet they still have an excellent outcome. So there's a disconnection between what you're seeing histologically and actually what the tumor behaves as biologically. So as you can tell, this does look a bit like an adenoid cystic carcinoma pattern. Here you can see what looks like profound adenoid cystic, right? Because it has these great cribiform architectural appearances. But then when you go and look at the surface, you will see that there is surface epithelial dysplasia. Sometimes that squamous differentiation will actually expand into and be seen within the neoplastic proliferation below as well. But generally, you will see it on the surface without any problem. And then, of course, these very small little ducts that you often see in adenoid cystic carcinoma will be present here as well. And hence, many of these cases actually came out of adenoid cystic carcinoma as an entity. So you would expect for a multiphenotypic carcinoma that there are going to be multiple different patterns with the immunohistochemistry, and specifically the ducts are highlighted by the CD117, while both components can be highlighted with S100 and SOX10. I will just say that if you do MIB immunohistochemistry, you can have a positive reaction, but if you do the FISH or rearrangement for the MIB gene, whether it's NFIB1 or a MIB L1, they are not present. And so this is a very confusing thing for some people, because they will do the immunohistochemistry and think it's an adenoid cystic carcinoma, and it is not. Now, along those same lines, a very strong and diffuse P16 is seen, but you do need to do a high-risk HPV RNA in situ hybridization in order to be able to include the HPV 33 to make sure that it is in fact positive, because there can be other tumors that will be P16 positive. In fact, some adenoid cystic carcinomas can express P16 immunophenotypically and yet not be related to transcriptionally active HPV. And so here is just such an example. You can see a strong and diffuse block-like immunoreactivity with the P16, and then, of course, the high-risk in situ hybridization. And it is important when you do it, many of the tests that are available are now quite specific. And so it'll actually say 16 and 18 only. And if that's all you do, it's going to come back negative in most of the cases, because it's related to HPV 33. So you do need to make sure that the high-risk panel that you're ordering encompasses the HPV 33 specifically. Okay, so I know that was a long presentation about the sinonasal tract, because there were several different things. Even though there were only a couple of new entities, there were a greater expansion of the diagnostic classification for many of the others. And so now let's move ahead to some of the other lesions. So within the nasopharynx, you'll notice it went from 19 diagnoses to 4, so we really kind of dropped the overall category. The low-grade nasopharyngeal papillary adenocarcinoma is the new name for a lesion that had been included previously, but otherwise not really any changes within the nasopharynx. It is interesting that, as you know, this is sort of an on-log-related tumor, and so in this case, you can see here is pituitary, because it's arising from Rathke's pouch area, and so here the pituitary papillary at the top of the nasopharynx is actually still included with this particular tumor, and therefore it can be quite an interesting lesion to diagnose. It is strongly positive with TTF1, but is negative with thyroglobulin, so you're able to recognize that it is not metastatic papillary thyroid carcinoma. I don't like that particular name at all. It is one of the names that we discouraged because people will often use the papillary carcinoma like, and we just don't want to use anything that has like in its name. So low-grade nasopharyngeal papillary adenocarcinoma is the new name. As you know, nasopharyngeal carcinoma is keratinizing or non-keratinizing. There are some slight differences in the differentiated versus the undifferentiated. These are not clinically meaningful. They're used primarily within areas that have a very high incidence in the endemic regions, but otherwise are not really that meaningful for general application. And of course, very strong association with Epstein-Barr virus, and the EBER as an in situ hybridization strongly highlights all of the neoplastic cells in nearly all of the cases. There is a very small subset that can be associated with transcriptionally active HPV, but you can't really make that diagnosis until you have excluded a primary in the oropharynx that may just be growing around to secondarily involve the nasopharyngeal region. As you know, the nasopharyngeal basaloid pattern can also be seen, same morphology, usually associated with the same EBV association. Now, having said that, you know, if I showed you this case and didn't give you any immunohistochemistry, I think you would also say, oh, okay, that's a great nasopharyngeal carcinoma. But in fact, it is not. This is a lymphoma and a diffuse large B-cell lymphoma. So it does tell you that sometimes the morphologic overlap between some of these categories can be quite subtle, and therefore we do need to have additional support for our diagnoses in many of these instances. I will say that the post-radiation carcinoma, residual carcinoma, is quite a difficult thing to recognize, but I think in this particular case, you can see that it's a very high NC ratio rather than a low NC ratio, which can be seen in just radiation change. And so it is important to recognize that in follow-up biopsies as well, many times the morphologic features have changed, and yet you're still able to recognize it. Now, they should also still have maintained the EBV association, and therefore that can be of assistance to you as you do evaluating these post-treatment related biopsies. So within the hypopharynx, larynx, trachea, and parapharyngeal space area, again, you can see this, major shift from 43 down to only 10 diagnoses, because of course we're only covering the lesions that are unique to this particular category. The major change here is just including some of the PD1 and PD-L1 expressions, since they can be guides used to predict overall patient outcome. And so we did feel that it was important to at least include those particular parameters as we talk about prognosis for these lesions. Now, again, the cartilaginous tumors, you may say, wait, you said in the beginning all of the things were kept in a specific category, so all of the bone and soft tissue things should be in one location. However, the reason for keeping the cartilaginous tumors only in the laryngeal chapter rather than incorporating it into a combined chapter is they are actually unique in this area. So if you think about the axial skeleton or the appendicular skeleton and the identification of cartilaginous neoplasms, where they've now taken on several different grading schemata. So in other words, you have the idea of it's a low-grade malignant potential category. Is it actually a chondroid neoplasm, or is it a chondrosarcoma? Can you use a category that is intermediate in order to be able to guide therapy? And the reason this is not included is only about 8 to 10% or so of cartilaginous tumors within the head and neck are associated with IDH1 or 2 mutations that are seen in almost all of the other types of chondrosarcoma. And so it is a different molecularly characterized lesion. Not a lot of the laryngeal lesions have been studied, but at this particular point, it is not the same driver. And therefore, we felt from a clinical management perspective, that particular terminology of unknown malignant potential or uncertain malignant potential does not aid the head and neck surgeon in their management of these tumors. And so we have continued the separation. As you know, the radiographic findings of this kind of popcorn-like appearance match with what you see grossly for these tumors, with multiple little swirls seen with calcification. And then, of course, it is often associated with ischemic change in an underlying enchondroma or chondroma that then transforms into the malignant cartilaginous tumor or chondrosarcoma. And so having both of those particular elements present in the same lesion can be quite helpful in coming up with the diagnosis. As you will notice in the ischemic change, it takes on this blue quality with a granular appearance in the cytoplasm, and that can be quite helpful in coming up with the diagnosis. Let's now transition to the salivary gland lesions. And, we always talk about, well, there's always a new salivary gland thing, but where were they? Well, I'm going to show you this, which is a painting taken from 1509 in the Papal Apartments by Raffaello. Of course, this is called the School of Athens, and here is the entire School of Athens. And you may say, well, what makes that unique? And what is this about salivary gland tumors? It's because of this dude in the far right, left-hand corner. Let's go and look at him on high power. Look at that. He has a salivary gland tumor, and I'm certain it's a pleomorphic adenoma just because it's grown out slowly. And who other than this particular model would show the tumor in the image? Anyway, salivary gland tumors have been around a long time. There's several new entities that we have included in this particular book, as well as having both the emerging as well as submerging. I mean, this particular terminology was added in for this book with the submerging, where we really didn't like the category at all. People didn't really want to include it, but thought, well, you can't just dump an entire diagnostic entity. So oncocytic carcinoma is kind of one of those things where if you do enough testing, you can often fit it into a different category. And so that is kind of a submerging category as we try to think about newer areas in which to be able to classify them, and hence the extinction of the NOS, the idea of not having a not otherwise specified tumor. Okay, many of them also were now classified when they had a canonical mutation that may be associated with them. And so in the definitions for these particular tumors, we actually did include most usually associated with, or most commonly associated, most frequently associated with, some terminology to that effect to show that while it is not the only mutation identified in many of these, it is certainly the one that is the most common, and therefore included it as well. Again, in this book, we tried very hard to include cytology. As you know, for salivary gland lesions or any head and neck tumor, in fact, it is very common to incorporate various fine needle aspiration findings prior to doing the surgical. And certainly molecular studies can be performed on fine needle aspirations as well to give a better classification if needed. So the fine needle aspiration findings were definitely incorporated. So new entity of sclerosing polycystic adenoma, previously called sclerosing polycystic adenosis. And this is because there are now identifications of P10 mutations, helping to confirm the presence of a neoplasia in this particular entity. Very classically defined by these fantastic eosinophilic cytoplasmic globules that are part of a tumor that shows both glandular, cystic, and kind of a hamartomatous-like appearance to many of the elements of this tumor. Keratocystoma is also a benign salivary gland tumor with multicystic squamous epithelium with lots of keratotic lamellae that dump keratin into the center. Very, very uncommon though, but still included as a new entity in this book. Likewise, the intercalated duct adenoma versus hyperplasia. These are benign salivary gland proliferations, bilayered, both epithelial and myoepithelial groups that look like intercalated ducts, and many times will have incorporation of acina differentiation in them. They tend to be in the parotid gland or major salivary glands and often have a multinodular appearance, although they are quite small. So it's very uncommon to have this as the primary reason for the surgical excision. It's usually something where it's been excised for some other reason, and then you can see this in the background or adjacent to one of the other tumors, for example, next to a basal cell adenoma or an epithelial myoepithelial carcinoma. So interestingly, in those lesions that do present more of a mass-like lesion, they have been associated with HRAS mutations, whereas those that are more of a hypoplastic or blending type appearance much more frequently are associated with CT and NB1. So this is a new entity included in this edition of the book. Now, sort of one higher up in the hierarchy with striated duct adenoma. This is also a tumor that presents only with striated duct differentiation, much more eosinophilic cytoplasm to it, with these very tall columnar cells as a single layer of neoplastic cells with a rich vascularity. They tend to also be remarkably uncommon, but still have been included in this book as well. And then microsecretory carcinoma, as you know, this is a entity that is defined by its molecular classification. So the MEF2C with SS18, same as what you see in synovial sarcoma for the SS18, but a very unique entity, usually in minor salivary gland locations, showing a SOX10S100 and P63 immunoreactivity pattern. Now, another one of the tumors that was included, even though it is really, really uncommon, is sclerosing microcystic carcinoma. This particular tumor looks identical to what you see in microcystic adnexal carcinoma of the skin, but this is recurring within the salivary glands, usually the intraoral minor salivary glands. And so you can see a very, very narrow bands of tumor, often associated with perineural involvement as well. And then the final entity here was mucinous adenocarcinoma. As you know, this is a tumor that is quite commonly associated with ACT1. It is a tumor that tends to be more often in the minor salivary glands, but of course can also be seen in major salivary glands, and has a variety of different architectural patterns, a variety of different mucinous appearances, and a variety of different cells that can compose these areas of mucinous differentiation. There's also still some controversy around this because of the intraductal papillary mucinous neoplasm category, whether that is part of this spectrum, a unique entity, or more on the benign end of this particular spectrum, because they also will have ACT1 mutations. So this is still something that needs to be developed over the ensuing months before we get to that final diagnosis. High-grade transformation, this has been harmonized for all of the salivary gland tumors as well, where there is a increase to sheet-like growth, tumor necrosis, remarkable number of increased mitotic figures and pleomorphism, developing in the setting of an otherwise background classical appearance to a recognized salivary gland tumor. And sometimes immunohistochemistry helps, sometimes it does not. Here you can see, sheet-like distribution, tumor, comedonecrosis, remarkable pleomorphism, not really much in the way of defining entity here, just, kind of sheet-like area here, almost giving you a micropapillary type architectural pattern. And in this case, it happens to be an example of a mucoepidermoid carcinoma that had undergone high-grade transformation. So many times these high-grade areas of transformation do not have zones of transition like you can see here, going from areas that show better mucinous differentiation, even though it's high-grade, into the rest of the tumor. And it is important before giving a diagnosis of high-grade transformation that you actually do recognize that it is something as an underlying tumor category. Many of these tumors have been in the NOS category previously, but now that we're able to define them, and especially on resection specimens, see areas of residual lower grade tumor that can be defined more easily, allow for this particular categorization. So when we talk about the oral cavity, again, a remarkable decrease in the number of entities, specifically because, of course, they have been removed out from all of the salivary gland lesions have been removed out, as have several of the entities that are hematolymphoid or bone and soft tissue. We did include some new entities like necrotizing salometaplasia and Hex disease and oral melanoacanthoma, kind of moving them around, but also including them because they can give you a clinical presentation of having a ominous appearance. So oral melanoacanthoma is that way. I mean, it looks for all intents and purposes like a melanoma. It comes on quite rapidly, but it has a very characteristic dendritic-like appearance to the melanocytic cells. They are not atypical. They have a very thickened overall epithelium, but it is something that you need to be able to recognize without putting it into a malignant category. Submucosous fibrosis, as you know, is a regionally associated pre-neoplastic condition, and the idea of including it here specifically around the fact that as you progress with these particular lesions, you are likely to develop a high risk of transformation to squamous cell carcinoma. Unfortunately, the early signs are quite minimal, but as you develop further, you get this homogeneous collagen deposition immediately below the surface epithelium, and ultimately loss of vascularity and very, very thick fibrosis that tends to ultimately have transition of the surface epithelium into squamous cell carcinoma. So incorporated now into the pre-neoplastic or precursor lesion category. As you know, the HPV-associated dysplasia can certainly occur in the oral cavity, though it is a very full thickness, keratotic, dyskeratotic appearance with these cells that are seen in a dyskeratotic appearance within the epithelium, very, very high NC ratio throughout, lots of mitotic figures, and of course, having a very strong association with HPV. Still, it is a very, very small overall dysplastic category within the oral cavity, and hence it is being separated out as a unique finding within the dysplasia group. I think it is important just to recognize that the carcinoma cuniculatum is a very unique entity, usually in the oral cavity. It occurs very rarely in other anatomic sites, but it's this volume of neoplasia with these burrows and furrows below the surface that arborize out all over. And so if you think about conceptually a verrucous carcinoma where it is growing exophytically into the lumen, a carcinoma cuniculatum is kind of the same concept, but growing endophytically into the underlying stroma, creating this very complex appearance. And I can tell you that when they do a biopsy, they are going to include just this little part over here, and you will be like, well, it's atypical squamoproliferative lesion. I don't know what you're talking about. And they're like, it's a 4-centimeter lesion. So this is one of the diagnoses that are remarkably classic when it is resected, but on biopsy material is just really treacherous and difficult to actually get to the diagnosis. So highlighting it here just to remind you guys that many times when people do a biopsy and they're only clipping through the surface and you can see little islands below, at least think about some of these entities that when they're doing a biopsy, they're not including the entire thing. Well, you know, 2005 didn't have the oropharynx at all, so this is kind of an embarrassment. Then in 2017, it was separated out as its own entity, and now we've, you know, harmonized the terminology down to just 3 diagnoses, as you know, HPV-associated and HPV independent. Well, you know, I like to kind of put things in historical perspective, as you can tell. So this is a really, really thick section, right? Here it is. All I'm doing is changing the light. You can see the neoplastic proliferation. Another example here, you can see the neoplastic proliferation extending down into the underlying very rich inflammatory stroma. And here you can see an area with even atypical mitotic figures present over here. And one final example, atypical mitotic figures. And I think you can get the feel that you're dealing with squamous differentiation. And so in this case, it's from 1885, right? So that's the reason why the biopsy is so thick. It was immediately placed into alcohol. This is the patient. I am not expecting anyone to just know who that is offhand. Here is a picture of him right before the tumor was identified. And so you may say, well, who is this? Well, you know, it's none other than President Ulysses S. Grant, and this happens to be his oropharyngeal squamous cell carcinoma, which ultimately was the cause of his demise. However, the reason why I'm including it here is because you will notice the specimen date was February 18 and the diagnosis was February 19. So you guys, turnaround time has not changed with the CAP or some of our other accrediting agencies. We have always been under the gun to produce a diagnosis really quickly. So the lymphoepithelium of the oral pharynx is an area in which there is not a basement membrane. So here's another area. So this is why there is no carcinoma in situ. We do not use that terminology within the oropharynx at all, because the lymphoepithelium is such that the tumor cells are intimately associated with the rest of the adjacent lymphoid component, and therefore you can't tell when it has, quote, breached a membrane, because there isn't a basement membrane to breach. So this is why a tumor like this, which is, you know, barely a few millimeters across, would really give you metastatic disease in the lateral neck lymph nodes. And so this is an example of a subepithelial tumor deep in the crypts. You'll notice a very strong and diffuse P16 immunoreactivity in a block-like appearance. And so again, for this book, we have separated them out into HPV-associated and HPV-independent. Of course, you can have a variety of different types under it, including non-keratinizing and keratinizing under either of these categories. And so it's important to recognize that about 5% of P16 positive tumors are not going to have transcriptionally active HPV, while the reverse, about 2% of P16 negative cases will have transcriptionally active HPV. So with that in mind, it's still important to remember that P16 is a great marker to be able to utilize for these particular tumors, very much clone dependent, with the E6H4 being the most reliable. And of course, it needs to be a strong and diffuse both nuclear and cytoplasmic reaction in more than 70% of the neoplastic cells. Now, sometimes it can be quite difficult. You know, if I did this as an image and said, what is that? oh, well, this just looks like some sort of reactive lymphoid thing. However, if you now look at the P16 for that tumor, it's strongly and diffusely reactive, right? So this happens to be one of the lymphoepithelial patterns. When you go a little bit higher, or maybe even on the highest magnification, you can see those neoplastic cells being positive for P16. So just recognize again that in the oropharynx, many times you may have problems with coming up with the diagnosis unless you have added on the various either keratins or P16 to get it into a category. Recognize as well that papillary subtypes can be positive with P16 as well. Here you can see a strong and diffuse P16 reactivity. And of course, because it is quite a complicated area, the data sets that are out are very helpful in coming up with the classification for these particular tumors. And we're actually in the process of updating them now with the new versions out in the beginning of 2024. I would also like to just highlight that the HPV-associated neuroendocrine carcinoma category is obviously present within the oropharynx most commonly, but because the neuroendocrine carcinoma is now its own entity, which I'll be discussing in the second lecture, just recognize that they can be strongly chromogranin or synaptophysin or INSM1 positive, as well as being associated with transcriptionally active HPV, and yet it doesn't seem to confer a better prognosis for these patients with the HPV association. So we do need to recognize this particular tumor group. So as you will now leave the, the love of my life, the oropharyngeal carcinoma, let's go on to some of the odontogenic tumors. As you can see, there's actually been a slight increase in the number of tumors, but the major focus for the odontogenic lesions was really moving things around. So trying to get a significant reorganization around the cysts of the jaw, whether they were inflammatory or odontogenic neoplasms in origin, then trying to separate out the various odontogenic carcinomas, and certainly separation based on whether they are associated with hard tissues or not. So in other words, the sarcoma and combination with a odontogenic, whether it's ameloblastic or not. So that was much of what was done in this particular area. But there was also a lot put into, because it is an uncommon area for people to recognize, we tried to put a lot of work into tables. And so, the decades at which things present most commonly, whether they are radiolucent or mixed radiolucent opaque or radio-opaque, and trying to help with separation between some of them based on the radiographic findings. Furthermore, we tried to separate them out into major entity groups. So the giant cell lesions as one of them, with what the major drivers were and when they are most frequently likely to be seen, as well as the fibroosseous lesions, and then of course separating between the bone and cartilaginous tumors, whether they are benign or malignant, and what the major drivers are for these particular entities as well. So I do feel that that particular work was very significant in coming up with ways in which people can approach some of these tumor types that are very uncommon, and therefore they may not come across in their daily practice. Now, surgical ciliated cyst, I'm just going to highlight several of them, but this is actually a iatrogenic lesion for the most part. It means someone had surgery before, and during that surgery, residual nests of epithelium were left, and then they develop a cyst later on. And so you'll get this very nice columnar epithelium, but forming a cyst, and therefore you do need to have the clinical findings in order to make the surgical ciliated cyst diagnosis. So it's not a neoplasm, but it is histologically distinctive. I mean, not really distinctive, but radiographically, it can be a mimic of multiple different odontogenic lesions. The adenoid ameloblastoma is a very specific category within it, showing a cribiform architecture with duct-like structures. This also has been recognized now to be associated with the BRAF pathogenic variants, and so it's important to recognize this as a subtype of ameloblastoma that is a unique entity within the head and neck space. Segmental odontomaxillary dysplasia was included primarily, again, because of the radiographic findings, where you may have crossover with some of the other lesions included in the differential. But in this particular instance, very, very few of the lesions are ever biopsied, because in fact, they have a classical, both clinical as well as radiographic appearance within the first 2 decades of life. But we decided to include it here as part of the differential consideration, just so at least you would have that as one of the entities to consider. Now, the TFCP2 rearranged rhabdomyosarcoma has been included here specifically within the jaw tumor chapter rather than being presented in the bone and soft tissue area or in the soft tissue entity, because this is the primary location. In other words, it involves the craniofacial bones, most commonly mandible and maxilla or skull bone, skull base. And so because it is a unique anatomic distribution for it, we felt, at least with the introduction of a new entity, to put it in where it's most likely to be identified. Now, it's a biphasic spindled and epithelial tumor that shows a very prominent keratin reactivity, but also then has desmin and MyoD1 myogenin, as well as having ALK and sometimes a number of other markers. And so this is one of the entities that if you do not do a panel approach, you're definitely not going to get to the right diagnosis. And so here I'll show you just an example. The surface epithelium is not involved, but I can tell you as I look at this, the idea that those particular cells may be kind of dropping off into this underlying area, and therefore spindle squamous cell carcinoma is a much more likely candidate. And we always talk about spindle squames being much more likely as entities in this location. So here is an example, a bit more rhabdoid, plasmacytoid on one side, spindled on the other. And yet when you look at it, it kind of has a more epithelioid quality to it. And so if you do a pan-cytokeratin, you can see strong diffuse reactivity. So if you're only doing one marker, that's it, right? You would have called this a spindle squamous cell carcinoma. However, if you add on the myogenin or MyoD1 or ALK, you will now see that it is co-expressed with these, and therefore it is really important to recognize that some of these newer entities that we are now classifying based on molecular morphology or immunohistochemical findings are only because panels have been utilized, and you suddenly say, wow, this I thought was going to be a spindle squamous cell carcinoma, and yet it's positive with myogenin. How can that be? And so you then begin to see that these tumors are quite different. And of course, they will have a different biology and a different outcome. And that's the reason for separating out from the other tumor mimics as well. So I'm going to end this conference now with the ear lesions, and you'll notice there's kind of a fluctuating number. We went from 37 in 2005 down to 14, and it's because it's a very complicated area, right? It's a super small space, and yet it's a very complicated anatomy, and so many of us are uncomfortable with dealing with lesions from this particular space. And so you may say, wow, there were a whole bunch of new entities. Actually not. I'm mortified to say that they were in the 3rd edition, and for some unknown reason just were not included at all in the 4th edition. They were just dumped. And so they are now being reintroduced, but they're not really new entities in that sense, because they just were left out. So, you know, we're not all perfect, and sometimes things happen. So, you know, I'll talk about osteoma just for a moment, because if you go back to mummies and you look at their skulls under imaging, whether it's X-ray or CT, you can see that they had osteomas. So they've been around forever, and they are still here with us today and are included now in the classification. So I'll end with the middle ear neuroendocrine tumor, because this is the one that has undergone the most taxonomic name change. And I will say, in my view, there are more names for this particular tumor than probably there are ever tumors that have been diagnosed, because each time someone does one, they take their 2 or 3 cases that they have and add it back to all of the ones in the literature. So the ones in the literature are repeatedly being used again and again and again. But anyway, just suffice it to say that the middle ear neuroendocrine tumor really is a unique category of neuroendocrine tumor. And it has always had this biphasic appearance where, you know, there's kind of a keratin component to it, but also strong neuroendocrine differentiation, sometimes having a luminal component versus the adjacent neuroendocrine tumor category. However, as more and more testing has been done on this tumor, it seems that it probably is more likely one tumor that is just showing slightly divergent differentiation with each of the various markers, and specifically probably related to the L cell of hindgut differentiation for most of these lesions. So the previous name of neuroendocrine middle ear adenoma, or NAME, probably is the closest one that accurately reflects the neuroendocrine nature. But since now all neuroendocrine tumors are separated based on grading system with the name of the anatomic site placed before it, so you have pancreatic neuroendocrine tumor, you have pituitary neuroendocrine tumor, now the same thing, you have middle ear neuroendocrine tumor. And so the grading of NET G1, 2, and 3 is probably going to be appropriate in this location as well, although I must say it is not as well defined yet, especially for the grade 3 group. Very, very multiple different patterns of growth. It does simulate an infiltrating adenocarcinoma type pattern of growth. When you look at it on low power, it will go into the ossicles of the middle ear, and therefore, if the ossicles are not removed, the patient will not really be cured of their disease. Here you can see multiple different patterns with kind of a plasmacytoid appearance in one area, a bit more of a glandulo-oasina type differentiation in another, you know, even kind of a secretory type material present here with these small kind of flattened luminal cells, although they do still stain the same way, except if you do some immunohistochemistry, which I'll show in a moment, you can see that there is kind of a biphasic appearance to many of these. So the neuroendocrine features can clearly be seen on H&E, where they have this nice stippled nucleochromatin. Even though it's a glandular appearance, sometimes they may even have a rosetted type appearance. So you'll notice the pancytokeratin accentuates and more strongly reacts in the areas of that kind of luminal appearance, which is the same thing with CK7, where you have this very, very strong reactivity within some of those luminal cells. And yet when you do some of the markers for neuroendocrine differentiation, when they are specific for the various neuroendocrine peptides, you can see here that islet-1 and SATB2, SSTR2A, giving you strong and diffuse reactions in these particular tumors. So with that, I would like to thank you for listening to this particular part of the presentation. I'm very happy to try and answer some questions at this particular juncture. I know that it does have a lot of new information, and that's only half the book. Thanks very much.
Thank you so much, Dr. Thompson, for this excellent overview of the part one of this new WHO classification of head and neck tumors. I have posted some questions in the chat box. Can you see them, Dr. Thompson?
Yes, I can. So let me just start off.
Yeah, sure.
Okay. The first question is about PD-L1 scoring in nasopharyngeal carcinoma. I mean, I think this is kind of a much more broad concept than just specifically nasopharynx. It isn't actually used in nasopharyngeal carcinoma very frequently, yet it's used much more in laryngeal squamous cell carcinoma because it just doesn't have the same concept of better behavior for patients, and the combined scores are still the same. So in other words, the idea of which particular analyte you're using, which antibody profile you're incorporating, whether you're getting to the combined scores of greater than 20 or not. So I do wish I could give you more on that, but this is very much something where each individual analyte that you're evaluating has its own criteria, and so they are not yet standardized well in these areas, as they have been in other anatomic sites like the lung system, as an example. Another question around any brush screening for HPV-related head and neck tumors. The short answer to that is no, not really. And the reason for that is most of the oropharyngeal carcinomas in which the transcriptionally active HPV is the most significant, the tumors develop deep in the crypt epithelium, and the brushes are only going on the surface epithelium, and therefore they quite frequently do not incorporate the actual neoplastic cells. Now, sometimes there may be environmental factors that are co-expressed within some of the cells of the brush, and so you may get epigenetic phenomena that are present in those smears or brush scrape type material. But at this particular point, they really are not going to be utilized very frequently. Same goes for sinonasal tract. In other words, there isn't really a brush cytology concept for the sinonasal tract either. So at this point, cytology primary is not really used for any of the HPV-related head and neck tumors. So there's a question about the low-grade nasopharyngeal papillary adenocarcinoma. The TTF1 is very strongly positive. I mean, I had mentioned that in the group, and again, highlighting the fact that there is not going to be reactivity with thyroglobulin, and that's the major way in which to be able to separate it from papillary thyroid carcinoma. That is a mimic, clearly, for these tumors, and therefore having some IHC confirmation is often quite helpful in that setting. The next question is around SMARCA4 and SMARCB1 deficient tumors. Can the same tumor be deficient in both? And the answer is there can be actually co-loss of multiple members of the SWE/SNF complex. It is very, very uncommon, however, And it is then something that would be defined by the RT-PCR findings rather than necessarily just the loss of SMARC A4 or SMARC B1, but it's an incredibly small group at this particular point. The follow-on to that is, do they have some morphologic overlap? And yes, they definitely do. I mean, there's some features that are seen more frequently in the adenocarcinoma category than what you see in the others, but the overlap is actually quite remarkable between them. And so I wouldn't necessarily say just on standard H&E, I would be able to predict, oh, this is more likely to be SMARC B1 versus SMARC A4. I think with more findings or a greater number of tumors that we're able to evaluate, perhaps we'll be able to do that. I mean, I'll just use secretory carcinoma as an example. When I first saw secretory carcinoma, I'm like, oh, I think I can recognize that. And so for, the next 8 or 10 cases, as I was doing the immunoevaluation, I would look at it and say, oh, is this something that I can do or not? And of course, it really is something where I think now I look at, oh, this is going to be secretory carcinoma. And then, of course, it is. So I think once you recognize the various category and the various features that you're able to see, I'll do the same thing with DECAF2 carcinoma. It's only recently recognized, but I went through several of my old cases and I thought, oh, this one is going to be a DECAF2 carcinoma, and do the molecular findings and it's positive. So I do think the very, very specific morphologic features that you can see within this definitely can be something that you can recognize in the future. So there's a question about intercalated duct adenoma is simply a monomorphic adenoma. Well, yeah, I mean, it depends how much you want to subcategorize lesions. The clinical management for intercalated duct adenoma, for pleomorphic adenoma, for striated duct adenoma, for basal cell adenoma, for canalicular adenoma, all of them are the same, right? I mean, they all have the same management, surgical excision. So for the benign lesions, your question is, do you need to separate them for management purposes? No, but, if I look at all of the skin tumors as well, separation of all of the subtypes of basal cell carcinoma, with the exception of maybe the sclerosing subtype, does it really make a difference to what they're going to do? And the answer is no, but we need to recognize them histologically to know that they are not fitting into some other category. So it's kind of an umbrella question to me, the idea of, should you recognize each of these tumors? I think, yes, it's nice to be able to recognize it as an entity, but still know that it is really expanding our histologic criteria for these entities rather than necessarily coming up with a new management for them. There's a question about olfactory neuroblastoma. Is it still there? Oh, absolutely. So, I only presented the lesions that were new and different or somehow included in a different location, but olfactory neuroblastoma is definitely still included. It's included within the sinonasal tract. So let me be clear again, it is a neuroendocrine type tumor, but we also recognize that olfactory neuroblastoma, or the recently recognized olfactory carcinoma, which is not yet quite included in the World Health Organization classification, it is as an emerging entity, but it isn't recognized yet as its own tumor type. But just know that olfactory neuroblastoma as an entity is a very specific one. It's a very specific anatomic site. It's a very specific biologic behavior. It has its own staging system. It has its own management system, where you're talking about what the clinicians are going to do for the tumor, the bicraniofacial approach, where you have neurosurgeons and head and neck surgeons simultaneously managing the particular surgery for the patient. So because it's just a very specific tumor entity, it's definitely still at this point within the sinonasal tract tumor classification rather than being within the neuroendocrine tumor classification. So as I said, the neuroendocrine tumors for this book is like the most massive change, and it clearly is, because trying to move all of the neuroendocrine expressing tumors or neuroendocrine pattern tumors out into their own chapter would cause quite a bit of consternation with a lot of people, hence leaving even the neuroendocrine tumor of the middle ear in the ear chapter rather than just pulling it out and keeping it as a net grade 1, 2, 3 type tumor within the NET category. So this is kind of goes on to the last question here that we'll do for this morning, and that is, do you differentiate NETs from NECs? And the answer is absolutely. So just as an overarching category, neuroendocrine tumors generally do not have global loss of RB. And so if you're talking about separation, especially with the grade 3 NETs, if you have intact or maintained retinoblastoma 1, you are probably still within the category of a neuroendocrine tumor, whereas if it's globally lost, you're more likely to be in the category of neuroendocrine carcinoma. That being said, this is still not well developed within the head and neck, but I do think that the NET grade 1 and 2 tumors, such as what were previously recognized as atypical carcinoids within the larynx, especially, that's probably the #1 location that we talk about these lesions, it is going to be a tumor type that clinically they need to recognize now, right? Because we used to call them moderately differentiated neuroendocrine carcinoma. Now that entire name is dumped, and now it's called neuroendocrine tumor grade 2. So that, as a massive change in how we approach these, is going to be different for management and also different for research. You cannot just go back and look for neuroendocrine tumors as an entity within the larynx, because you're just not going to come across them. So you're going to have to look at old neuroendocrine carcinoma and grade 1, 2, and 3, recognizing that probably the old terminology for neuroendocrine carcinoma grade 3 includes NET grade 3, as well as neuroendocrine carcinoma of both the small cell and large cell category. So it is a definitely emerging field. There is still a lot to be able to do to categorize these much more regularly and definitively than what we have done up to this point. And so, if I can use the analogy for both the gastrointestinal system as well as the lung, where, the lung people still use atypical carcinoid. They are so resistant to the idea of using neuroendocrine tumor, grade 1, 2, and 3, and small cell carcinoma or large cell carcinoma. So this is really where I think the idea of having the best overall approach to these lesions globally is going to make a much better overall diagnostic classification. When you talk about these classifications, it is always important to recognize the difference between a high-resourced country and a low-resourced country. So I can tell you that when I was at the AFIP, I would look at a case and say, this is going to be a neuroendocrine tumor based on morphology, right? So morphology is still the driver for neuroendocrine tumors. If you do not have neuroendocrine differentiation histologically, it doesn't really matter what you have expressed immunophenotypically, you still need to have both of those things in combination in order to make the diagnosis. And so when I look at neuroendocrine tumors, I still want to be able to have H&E criteria, and then I can count mitotic figures, or I can do a Ki-67, or I can do one immunohistochemistry in order to be able to at least highlight neuroendocrine differentiation, such as something like chromogranin or INSM1. But if you don't have either of those things, you can still say, this is consistent with a neuroendocrine neoplasm, not further specified, see note, and then in the comments say, the resources to further classify are not available. So this is where the concept of the extinction of NOS is where I would like to see us go. We cannot remove it completely when you don't have the resources to do it. I spent several weeks a few years back in Ethiopia, where the first fine needle patient that I saw, I said, oh, this is Rosai-Dorfman disease. And that was it. There was nothing else. There was no S100. They were not going to do any additional findings. They were not going to do any more workup. There was not going to be a core needle biopsy. In that particular setting, with a patient who had walked in from a rural area, they were going to be managed that very day based on my particular diagnosis. I mean, obviously, the rest of the people there agreed with me, but I can just tell you that sometimes in the resource low areas, you can still make an interpretation that is clinically actionable without worrying about necessarily having to do all of the various immunohistochemistry to get you into a specific group. If you're going to do a molecular classification, it's because theoretically there is an alternative to management that can be based on that particular molecular finding so that the person is managed differently. If I look at secretory carcinoma, you know, the ETV6 NTRK fusion, if that's present, and you know that the person is going to receive therapy because that particular fusion is present, then you do RT-PCR to confirm it so that you're giving them the right chemotherapy agent. So there, you're using a molecular classification, but it's because you know that you're going to have a target for metastatic disease, not just because you need to have the result in order to get the diagnosis. Anyway, thanks very much. I have appreciated this opportunity, and I look forward to, I think it's next week, that we'll have another session for the second half of this particular group.
Thank you so much, Dr. Thompson. This was an amazing talk, and I'm sure everybody enjoyed it. And we had the viewers who joined from so many different countries. I could keep track of our colleagues who joined from far off places as far as Afghanistan, Kenya, Nigeria, India, Czech Republic, Ukraine, Cambodia, Myanmar, Denmark, to name a few. And many of our viewers have questioned or expressed concern about always coming up with new entities. And as you have rightly mentioned and answered the question, that if there is a question about resource limitation, then definitely, we have to stay with the limitations and do the best as we can. I mean, otherwise, but it's always important to move on and define new entities, as you rightly said, because it's an era of precision medicine. And if there is a targetable or driver mutation which can be acted upon, so then that is helpful to the patient to get the right treatment where resources are available. Thank you again, Dr. Thompson. And as you have mentioned that our part 2 will be coming up, and that is on actually next Tuesday. So that is October 24th, and it's at the same time, 12 p.m. Eastern time, and hope to see you all on October 24th for part 2. And thank you so much, everyone.
Thanks.
And thanks, Dr. Thompson.
Have a good day.
Bye.